Hi everyone. We are here from StudyMEDIC, and I'm Mentor, and we are here with Flash Reviewing YouTube series. The topic that we are going to discuss today is subfertility module. We know that one of the most important module is subfertility module, and by the end of this presentation, you will get to know about the most important exam questions that are going to come. Always remember consistency and discipline towards success. At the end of the day, it's your hard work and luck that decides your fate in the examination hall. So, the topics that we are going to discuss today is PCOS, ovulation induction, male infertility, endometriosis, and infertility management. These are some of the most important questions that are going to come in exam, and you need to have a very good grip on these topics. There are two types of questions that come in exam. One is SBAs and another one is EMQ. SBAs have limited options. So if you have good grip on SBAs, you can easily ace that portion in the exam. Like 50% in paper 1 and 50% in paper 2 comprises SBAs, and 50% in paper 1 and 50% in paper 2 comprises EMQs. SBAs are like easy money. If you have a good grip on them, you can easily ace them. Let's start with the question number 1. A 25-year-old woman was noted to have hirsutism, acne, and male pattern baldness. BMI was noted to be 27. What is the most likely diagnosis in this patient? A. Polycystic ovarian syndrome. B. Congenital adrenal hyperplasia. C. Androgen insensitivity syndrome. D. Cushing syndrome. And E. Androgen secreting tumors. I always want you to remember that if you have a question like this, always remember that sometimes the thing that is the most common can be in the option 2. So always go from the least problematic thing to the most problematic thing. All right. Answer in this question is polycystic ovarian syndrome. Most of the population have this problem, and they will have these kind of symptoms that include hirsutism, acne, and male pattern baldness. Let's go to question number 2. A 28-year-old woman is planned for ART, and the investigation shows AMH is 28, FSH is 4, and AFC, that is the antral follicle count, of 20. What is the preferred GnRH protocol for the controlled ovarian stimulation? GnRH antagonist and minimal FSH, GnRH antagonist and maximal FSH, GnRH agonist and minimal FSH, or agonist with the maximal FSH, and GnRH antagonist and the standard treatment. So in this case, I want you to know that there are certain things that are pointing towards that this patient is going to show a high response if we give her a lot of medicine. So in this case, the answer will be GnRH antagonist and minimal FSH. So if you look at this, the patients who have high antral follicle count and high AMH, in this case, if we give them GnRH antagonist with minimal FSH stimulation, they show a good response. On to the question number 3. A 31 years old is referred by GP because of primary infertility of 2 years duration. She was previously on the combined OCP for 7 years. Her cycles are irregular, ranging between 35 and 47 days. Her BMI is 38 kg per meter square, and the baseline investigation show an FSH level of 5.2, and an LH level of 8.3, and estradiol levels of 153. The ultrasound of the pelvis is suggestive of polycystic ovaries, and her partner semen analysis is normal. What is the next step in the management? Now, always remember that most of the questions will come from the guidelines. Take guidelines as a flowchart. Always remember all the steps. So in this case, the one warning sign that we are seeing is her BMI, that is high. So the option will be A, weight loss. In this case, first we will offer her weight loss, and then afterwards we can offer her some management options that are listed below. All of the options are right, but we need to tell the next step in the management. Question number 4. A woman with a BMI of 28 and polycystic ovarian syndrome has attempted ovulation induction with clomiphene citrate and metformin without success. She now returns to the clinic and wants to know her further management plan. She prefers surgery as the last resort. So, A, anastrozole, B, cabergoline, C, follicle-stimulating hormone injections, and D, laparoscopic ovarian drilling, E, letrozole. In this question, the examiner has already told you that she does not want to undergo surgery. So the best option in this case will be C, follicle stimulating hormones. And NICE guidelines suggest that either give her the option of clomiphene citrate or metformin, and if it's not working, give her the option of gonadotropins or laparoscopic ovarian drilling. Question number 5. Which hormone level is affected by ART conception? Number 1, estradiol. B, beta-HCG. Number 3, prolactin. 4, pregnancy-associated plasma protein A. And number 5, progesterone. So in this case, the research shows that number 4, pregnancy-associated plasma protein A levels are affected by ART, and the levels have shown to be decreased. Now, the same question can show in a way that if a patient gets pregnant by ART, what will be the false positive level in this case? So in that case, the answer will be beta-HCG. I'm sure that it cleared some points. Question number 6. A couple reports with primary infertility. Investigations reveal azoospermia and reduced FSH levels in the husband, who is a gym trainer. Most likely cause: A, Klinefelter syndrome. B, Coleman syndrome. C, CBAVD, congenital bilateral absence of vas deferens. And number D, anabolic steroids. And number D, cryptorchidism. So in this case, the most probable option that we need to go towards is the use of anabolic steroids. A 38-year-old man with male factor infertility was evaluated. Patient was found to have oligospermia and FSH was found to be very low. What is the most likely diagnosis for this patient? A, Coleman syndrome. Number B, Klinefelter syndrome. C, varicocele. D, surgical trauma. And E, ejaculatory failure. So in this case, the patient has already very low sperms and the FSH is found to be very low. The best diagnosis in this case is hypogonadotropic hypogonadism. And the answer is A, Coleman syndrome comes to mind. Especially these kind of people have some problems with the sense of smell too. It's a pretesticular option. Question number 8. Which of the conditions are associated with tubo-ovarian abscess? A, endometrioma. B, ovarian cyst adenoma. C, ovarian cyst. D, polycystic ovarian syndrome. And E, fibroid uterus. In these cases, if an option comes, you need to think of adhesions. And the most common adhesion formations are with endometrioma. All right. Question number 9. Which of the following is the next most appropriate diagnostic test to perform on 20 years old woman who was referred with secondary amenorrhea and hirsutism? She states that her older sister had similar problem and the results of blood tests taken by her GP were as follows. So the prolactin is normal, it is 460, testosterone is raised 6, sex hormone binding globulin is 22, FSH is 1.9 and LH is 7.8. Estradiol is 102 and HCG is less than 5. So what is required more in this patient to come to the diagnosis? A, abdominal CT. B, cranial MRI. C, dexamethasone suppression test. D, 17-hydroxyprogesterone test. Or E, ACTH stimulation test. So in this case, we need to come to the diagnosis. So in this case, the option will be 17-hydroxyprogesterone test to come to the diagnosis of congenital adrenal hyperplasia. First, we will do this test and then confirm with ACTH stimulation test. We cannot confirm it right away. Adrenal glucocorticoid secretion is controlled by adrenocorticotropic hormone released by the anterior pituitary. So it is confirmed by ACTH stimulation test, but we need to undergo the first test that actually diagnoses the condition. All right, question number 10. A 28-year-old woman presenting with subfertility has regular menstrual cycle. On ultrasound, the ovaries are polycystic. Which of the following tests you will advise to diagnose polycystic ovarian syndrome? Is it total testosterone, FSH over LH ratio, free androgen index, serum prolactin, or serum TSH? The answer will be C. In this case, the free androgen index, which is basically total testosterone, this divided by sex hormone binding globulin multiplied by 10. Only this question, that what is the definition of free androgen index, can come in the exam. And they can ask you any of the above, numerator or denominator. And in this case, it is the one thing that is used to make a diagnosis of PCOS. Question number 11. A 35-year-old male was found to have FSH 35 and LH 24, testosterone 2, and normal growth karyotyping was found to be 46XY semen analysis. And the semen analysis showed azoospermia. What is the most likely diagnosis for this patient? So when we see there is hypergonadotropic hypogonadism, and in this case, what can be the cause? Most of the times, it's just the obstructive cause. The post-testicular cases, then the causes include surgical trauma, vasectomy, infection, and congenital bilateral absence of vas deferens. Sometimes they won't ask you an obstructive cause as an option. They will ask you a specific thing and they will give something in the scenario to complete the whole scenario. Question number 12. A 39-year-old woman who has not conceived after 2 years of unprotected intercourse is undergoing IVF treatment for the first time. She becomes 40 during the course of the treatment, and how many more cycles of IVF can be done in this patient? 1, 2, 3, or complete the current IVF cycle and stop the treatment immediately. So it's written in nice guidelines that we need to complete the current IVF cycle and stop. In a woman aged under 40 years who have not conceived after 2 years of regular and protected sexual intercourse, or after 12 cycles of IUI, which 6 or more by IUI, and offer 3 full cycles of IVF, with or without ICSI. If the woman reaches the age of 40 during the treatment, you need to complete the full cycle, but do not offer any more cycles. Question number 13. A 17-year-old with primary amenorrhea. She is sexually active and breast Tanner staging is 4/5. Axillary and pubic hair of Tanner stage 2 development. Her height is 1.65 and BMI is 19. Pelvic ultrasound shows that uterus is absent. Serum testosterone is 16 nanomole per liter. What can be the diagnosis? Polycystic ovarian syndrome, premature ovarian failure, Turner syndrome, androgen insensitivity syndrome, or prolactin secreting adenoma. So in this case, we need to see that she is sexually active and breast and Tanner staging is 4/5. That breast is developed. Axillary pubic hair Tanner staging of 2 development. The answer will be D, androgen insensitivity syndrome. In most of these patients, the axillary and pubic hair is not as well developed as the other stages of development. So in this case, there is a small chart that you can use to make a diagnosis. In this case, if she had absent menses with normal secondary sexual characteristics and an absent vagina, the most common thing that must come to mind is Mayer-Rokitansky-Kuster-Hauser syndrome. Apart from that, if she has sudden onset of hirsutism, we can think of congenital adrenal hyperplasia. Now on to the question number 14. In the last question, if we do the karyotyping in this patient, it will come out to be 46XY. All right. Question number 14. A 34-year-old male with abnormal semen analysis and varicocele. Next treatment. Do we offer surgery? Don't offer surgery for varicoceles. B, varicocelectomy. C, screening for anti-sperm antibodies. And D, repeat in 6 months. So, according to the NICE guidelines, A, approximately 20% of the males diagnosed with varicocele will have fertility problems. The incidence of varicocele among men with primary infertility is up to 44, but NICE guidelines suggest that we do not recommend surgery for varicocele solely to improve fertility. The last questions in SBAs. Male semen analysis shows the sperm count is 6 million and the progressive motility is 30% and the normal morphology is 5%. What we need to do next? Repeat semen analysis in 6 months, repeat semen analysis in 3 months, offer IUI, offer ICSI, or offer semen analysis as soon as possible. So this is the semen analysis that shows a little bit of a problem. In this case, we will offer him the semen analysis in 3 months or 12 weeks, option number B. And if there is a drastic problem in semen analysis, we can offer it right away. All right. Let's come to the EMQs now. These are the questions that have similar options and a lot of options. And most of the time students get confused. An exam, you have such little time and you're already confused. So I will make sure that we discuss the most important ones that have come in the exam so far, so it can help you in your exam. So question number 1. A 30-year-old woman with normal ovulatory cycles was under investigation for infertility and her tubal patency and pelvic ultrasound was normal. we need to do three things when a person comes with infertility or with unable to conceive. We need to see her ovarian function test, we need to see if her tubes are okay, and we need to see that if semen analysis is okay. Her partner semen analysis is as follows: semen volume 0.5 ml, sperm concentration 5, progressive motility 4. What is the most appropriate plan of management for the couple? So what is the problem that we are seeing in this case? The patient is all right. With the semen, there is some issue going on. IUI with donor insemination, ICSI with donor sperm, IUI, IVF with donor insemination, surgical treatment of the partner, surrogacy, and surrogacy with the donor sperm, and surrogacy with donor egg and donor sperm, or IVF with the donor egg. We see there is a little bit of a problem, so we can offer her ICSI. For that, you need to know what are the indications. If there is severe defects in semen quality, if there is obstructive azoospermia, if there is non-obstructive azoospermia, in these cases, if there is any problem like that, you will directly offer her ICSI. Question number 2. 20-year-old infertile couple attended the fertility clinic with the primary infertility. They have been trying to conceive for the past 24 months. It's been 2 years. She was found to be normal during a diagnostic laparoscopy done recently. During evaluation, her partner's semen analysis is 29 million per ml. And what is the most appropriate management plan? Conservative management, ovulation induction. With all these options that you have available, we need to see what is actually going on. They have been trying to conceive for the past 24 months, and she was found to be normal. And her partner semen analysis is 29 million per ml. In this case, we directly offer her the management plan of referral for IVF because they have been trying to conceive for the past 2 years. And mostly it becomes a case of unexplained infertility. Apart from that, now let's go to question number 3. A couple who has been trying to conceive for the past 3 years came for the evaluation of infertility, and she complains of oligomenorrhea. Her day 21 serum progesterone is 5, serum FSH is 1, LH is 1, and thyroid profile is normal, and serum prolactin level is normal. So in this case, what is the option that you will give her? So we can see that her FSH and LH levels are low and her serum progesterone level is low. So in this case, what we can help her? How can we help her? We can give her something to increase the levels of LH and FSH. And how can we go to that? Among all these options, the best option that we can see is pulsatile GnRH agonist. In these cases, if we give her this, it will increase the level of FSH and LH, and there is a chance that she can ultimately produce eggs. On to the next question. A couple is trying to conceive for 1 year. An investigation was done which showed FSH, low testosterone, low semen analysis showing azoospermia on 2 occasions. Female partner reports normal. What is your advice? So it shows hypogonadotrophic hypogonadism. And we have already discussed when there is some problem with male factor, what do we offer him in this case? The best option comes is ICSI. Severe defects in sperm quality, obstructive azoospermia, non-obstructive azoospermia. The NICE guidelines suggest that in this case, the best possible thing that we can give to the patient is ICSI. Question number 5. A 40-year-old man is investigated with his wife for secondary infertility, and his semen analysis shows asthenozoospermia. He has been suffering from chronic productive cough and sinusitis for the past 2 years. Now, what do you need to understand is he's 40 years old, he has secondary infertility, and he has been suffering from chronic productive cough and sinusitis for the past 2 years. When somebody thinks about it, the first option that comes to the mind will be that he must have some kind of cystic fibrosis. But when you come to look at the history, it's not that far off. From the options that have been listed here, the best option that comes to mind is option H, immotile cilia syndrome. A combination of asthenozoospermia and chronic cough in this patient would suggest the immotile cilia syndrome. So if a patient who comes to you who has a long-standing history, in that case, it can be congenital bilateral absence of vas deferens, and it can be cystic fibrosis. But in this case, it's a short-term history, and he has had kids before, so it's immotile cilia syndrome. Okay. Now, question number 6. A 20-year-old infertile couple attended the fertility clinic with primary infertility, and they have been trying to conceive for the past 24 months. She was found to be normal during a diagnostic laparoscopy done recently. During evaluation, her partner semen analysis is 29 million per ml, and what is the most appropriate management plan? All right, so this is the same question that we discussed before. We have to refer her for IVF. Question number 7. A 24-year-old nulliparous woman has come with complaints of secondary amenorrhea. Her periods at first were very light and infrequent and lasted for 12 months, after which it disappeared. Patient also has hypothyroidism with a TSH of 10.45 and FSH is elevated to 72 LH. 72 LH is elevated to 40. What is the diagnosis that is most likely in this patient? So, in this case, all the options have been given to us. The investigations that have done so far shows that FSH is elevated. In this case, if FSH is elevated, she most probably has some sort of premature ovarian insufficiency. So, if there is some issue of premature ovarian insufficiency, we need to see other problems that have been associated in this case. You also have hypothyroidism. So, all the cases, and she has secondary amenorrhea. If she had primary amenorrhea, she could be a case of Turner syndrome, but she has secondary amenorrhea. So, in this case, she is a case of option I, Turner mosaic. She has all the characteristics in this case. I know it's a tricky question, but if a person comes with primary amenorrhea, she must have been of Turner syndrome, that is simple Turner syndrome. But she has had very light period in the start, and after which it disappeared. She has hypothyroidism, and her values of FSH and LH are elevated, so she is most probably a Turner mosaic. All right. So, question number 8. Infertile couple and semen analysis on 2 occasions shows azoospermia. How to manage the case? We have the same options that we have discussed here. Now it will come to your mind that we can offer her IUI or any other option, but the most important option that you can give, the most important management option that you can give to this patient is ICSI. If male has some sort of problem, you have to offer ICSI. You have to take ICSI right away. All right. Male is HIV positive, semen analysis is normal, female reports show normal, they have opted for ART. And which of the following options is suitable? So, he is HIV positive and everything is normal, and they have opted for artificial reproductive technology. In this case, we need to remember the indications of intrauterine insemination. We can offer them to patients who have to undergo donor insemination, who are in the same sex relationships, whose partner have some kind of problem that needs sperm washing, like hepatitis B or HIV, or who find it are unable to have sex or find it very difficult to have sex. So, among the options that have been listed in before, we need to give IUI with 6 cycle without ovulation induction, because that's what the NICE guidelines suggest. NICE guidelines does not suggest IUI with ovulation induction. All right. The gold standard diagnostic modality for MRKH is, so in this case, the gold standard diagnostic modality for MRKH syndrome, all the options that have been given, the best option that comes to mind is MRI. And diagnosis is based on radiological findings. So we need to have an MRI to actually see the absence of uterus and cervix. All right. Question number 11. In this case, the husband is normal. Male partner investigations are normal. Female partner investigations show the hysterosalpingography, proximal tubal block. In these, the options include IVF, IUI, ICSI, oocyte cryopreservation, sperm donation, IUI, salpingectomy, and the last options include selective salpingography with tubal catheterization. And we know that the NICE guidelines suggest that the woman who has mild tubal disease, tubal surgery may be more effective. And with proximal tubal obstruction, selective salpingography plus tubal catheterization is the best option that we can offer to these patients. All right. So there is an infertile couple. The husband previously fertile, but now semen analysis shows azoospermia with low FSH. What is the most probable cause in this case? Okay, that is a very important question. Klinefelter syndrome, Kallman syndrome, cryptorchidism, anabolic steroids. This is one of the AMQs that we have discussed in the form of SBAs before. There is a very big giveaway in this AMQ. The husband was previously fertile. It means he may have some kids before. So in this case, they may give some history that he goes to the gym, but in this case, the best probable option that comes to mind is anabolic steroids, because the steroids effect that shows the labs in which the patients has FSH levels and testosterone levels drop. So in this case, what happens is that the patients who have anabolic steroids, they can have these kind of symptoms, but they were previously fertile. Okay, question number 13. An infertile couple, male has history of cystic fibrosis and azoospermia. On testing, serum FSH is normal testicular volume, and on biopsy, there is evidence of complete spermatogenesis. So what can be the option in this case? Now, when we go back to the options, the best option that comes to our mind is J, congenital bilateral absence of vas deferens. That mostly happens in the people who have cystic fibrosis. And question number 14. A 15-year-old girl with primary amenorrhea with hirsutism and acne, mother says that the patient has surgery of vulva clitoromegaly when she was a child. So, among all the options that have been given here, the first most important, the most commonest option that comes to mind is congenital adrenal hyperplasia. That is the option E. And in this case, patients have male pattern baldness, they have thickening of their voice, they have clitoromegaly, and patient has already undergone surgery for that. And the last AMQ. A 30-year-old woman who is on the waiting list for IVF because of unexplained infertility of 3 years duration. And she had an ultrasound week ago and it showed 2 into 3 centimeter left and 2 into 2 centimeter right endometrioma. So among all the options that you see in this case, what will be the best option? Now we have to see that she has endometriosis. Is the endometriosis causing problem in this patient? Does she has any kind of symptoms associated with the pain? If no, we do not offer surgery in this case. But if yes, we can consider to offer surgery in this case. But we need to tell that it will reduce her ovarian reserve and we need to offer her some kind of ovarian preservation techniques before that. So in this case, the best option, according to ESTRA guideline, would be proceed to stimulation of superovulation and IVF. That is the option number U. Because she is planning for ART, we can do the superovulation, we can offer her IVF. That is a higher success rate as compared to the other management options. All right. Thank you so much. I believe that it kind of helped you in some way, and best of luck for your exams. And always remember that keep a control on your nerves, eat good before the exam, sleep good before the exam, and I'm sure you can ace it. It's not how well you know. It does not determine your worth as a clinician. It's just how well you perform during that exam. Best of luck and thank you so much.